Okay, so what is that? Can you understand? Oh, it's not a very good picture. Have a look at this then. What do you think?
Yes, sir.
Yeah, what is it?
Uh, yeah, this is a plain radiograph of the skeletal mature individual documented, north side documented. I can appreciate, sir, there is increased sclerosis in the lunate. It may be a Kienbock's disease.
Okay. So do you know the classification of the Kienbock's disease then?
Uh, Sir, I don't recall the name, sir. In stage one, there is no radiographic findings, but there is findings in the MRI in the MRI and bone scan. In two, there is sclerosis. Three, there is cell collapse. Four, there is
Collapse with arthritis.
arthritis,
Yeah.
arthritis, and positive ulnar variant, sir.
Okay, so positive ulnar variant is not present in all of them, but it is
Okay.
in some patients. So they present with what sided pain? They have wrist pain, but what sided, radial or ulnar side pain?
Sir, radial sided.
Okay. So how once you've done an investigation and you found this person has got an MRI findings, not like this, but an MRI finding, what is your plan of procedure for those?
Sir, I would like to counsel the patient of his disease. I would see if it is occupation, if it is an executive worker or a laborer.
Okay.
So, sir, I would advise them, sir, if in early stages, for either wrist brace or for conservative or core decompression, sir.
You can do that, but before you do core decompression, you want to make sure the ulnar is not positive, and you can do an ulnar shortening procedure for them.
Yes, sir. Yes, sir.
In stage two,
So stage two, there is a sclerosis development. I would like to, so if it's the height is, there is no loss of height or arthritic changes, I would like to perform a pedicle vascular pedicle graft for
okay,
the lunate.
okay. So when you see X-ray findings, they are already dying, isn't it? There is basically every ivory-like bone formation. You can pedicular vascularize it, but the better operation is to take the pressure off the lunate. And how do you do that?
Sir, I would like to, SCT, sir, orthodesis, sir.
Good. So you make a pillar. The pillar is made on
Yes,
the
sir.
radial side. You take the scaphoid, trapezium, and trapezoid. So you fuse them. It's called an STT orthodesis. And by fusing them, the capitate does not drive down. So therefore, the pressure on the lunate is decreased from the capitate being held stable by the STT orthodesis you do. Okay. So in the
Yes,
third
sir.
stage,
Uh, Third state, I would like, sir, either pan orthodesis of all the carpal bones or
so for the wrist to move, you need to have a lunate. Okay.
yes, sir.
So if that's not working and fragmented, you can do a denervation procedure. You can replace the lunate, which has got poor results, or you can do a proximal row carpectomy.
Carpal bacteria, yes, sir.
Yes, yes. Okay. So for the arthritic one, then you do a pen wrist fusion.
Pan wrist orthodesis, yes, sir.
Okay, good. It's good. Yeah, you guys know your stuff. It's just you need to have confidence to tell them, isn't it? What about carpal
Thank
tunnel
you, sir.
syndrome? What about carpal tunnel syndrome? Describe what is carpal tunnel syndrome.
Sir, it is the compression of the median nerve through when it passes through the transverse carpal ligament, sir.
Okay. So why do they have pain at night?
Sir, because there is loss of the wrist flexion, sir, which causes the nerve impingement. The patient will relax during the night and a extension posture, sir, that will compress the nerve.
Okay. So what happens is when you go to sleep, okay, when you go to sleep, this is called a fetal position. You are in your
Fetal position, yes, sir.
most comfortable position that you go to sleep. So in the fetus, all your wrist is flexed, elbow is flexed, hips are flexed, and knees are flexed, so that you can, do. Sorry, not hips are flexed. Yeah, the hips flexed, knees flexed, the whole lot is flexed. So when you flex your wrist, you are doing your Phelan test anyway. So when they go to sleep,
Yes, sir.
Phelan test, and therefore they have symptoms at night. Okay. So the easiest thing to sort this out is to give them a splint to stop them from flexing their wrist at night time. That's the first thing. Okay.
Yes, a night brace, sir.
Exactly. What now you understand why you give a night brace, isn't it?
Yes, sir. Yes, sir. I was confused as a flexion and extension.
So when you understand, then it's easier rather than lakir ka fakir. पहले किसी ने कहा
Yes,
हाथ का
sir.
strength देना है
Yes,
तो
sir.
हाथ का strength देना है. You need to understand. Okay. So what will you do to confirm a diagnosis of carpal tunnel syndrome?
Sir, the most sensitive I would like to clinically assess with the Durkan's test, sir.
What? Sorry.
Durkan's test, sir.
What's the
Durkan.
Durkan's test?
Sir, it is the direct compression of the median nerve
Okay.
when the wrist is wrist extension.
So you are trying to tighten the space for it, isn't it? So, but
Yes, sir.
it is not as sensitive and specific as other tests. So what tests are more sensitive and specific? So the Phelan test is most sensitive and
Well,
specific, yeah? And then
yeah,
there's
final test is the sensitive.
and then
Yeah.
you do a reverse Phelan, which is even more sensitive, and a direct Tinel is like tapping the nerve, which means that the myelin of the sheath has gone. It's bare
Hmm.
because of the compression, and therefore it is hypersensitive and they have Tinel. So these three tests are very sensitive. If you have a history, knife, pins and needles, dropping of things, okay, unable to use the hand, and one of the three tests positive, then that's pathognomic of a tight compartment syndrome or a carpal tunnel syndrome. Yeah. So
Right, sir.
okay, so that's the question. Then so what test physical if you want to do a lab test, what would you like to do?
Uh, Sir, nerve conduction study, sir.
Very good. What will that show you?
Sir, there will be the increase the latency, sir, of the
There are
signals.
three things it will show you. From the
Yeah.
time of stimulus, when the stimulus is gone till the time the first wave comes up, i.e. the latency, it is prolonged.
Yes, sir.
The complex duration is longer.
Complex duration is longer.
Yeah, it takes longer for the nerve signal to pass. And third, the complex is shorter. You know, it's
Yes,
hyper.
sir.
So these are the three pathognomic features of carpal tunnel syndrome. So what would you do if you had carpal tunnel syndrome and you wanted to operate on somebody? What would you tell the patient and how would you go ahead?
Sir, I would like to first offer a conservative procedure if the give him a nighttime brace and also wait for a couple of months, sir. If there is no response, I would like to inject steroids, sir,
Okay, there you
and
go.
xylocaine into the compartment,
Don't
sir.
inject steroids into nerves. Bad thing. So what does a steroid do?
Sir, the steroid uh, sir decrease this uh, inflammation, sir, surrounding the nerve, sir.
Okay, so the steroid is an anti-inflammatory. Okay,
Yeah.
so when you have something wrong in the body, then there is a response, and the response is inflammatory. Okay, because on its own it cannot help itself, so it asks for help by secreting mediators. The mediators are intraleukin, tumor necrosis factor alpha, and various other things. These things cause pain and edema and swelling. So if you put a steroid into something, it will temporarily make them better because you stop the process of repair. The inflammation has been stopped. So it will give you a test, but it will never treat anything for you. So it will temporarily make it better, but it will never treat anything for you. Okay, so steroid
Mm.
you can do as a test, but not as a treatment. Okay, so,
Okay.
so age is very important in carpal tunnel syndrome. And why is age important in carpal tunnel syndrome?
Sir, again, sir, if it is very young, it can be related to pregnancy and the recurrence
No,
as
no, no.
well.
So nerves don't like age and don't like duration and don't like compression.
Okay,
The
okay,
older
okay.
you are,
Elderly will be poor prognosis.
yes,
Yeah,
the older you are, the worse the prognosis.
the worse it will be. Say,
The longer the duration, you know, if you have more than 6 months, more than a year, more than 2, the worse the prognosis. Okay, and the severe the compression, the worse the prognosis. Okay, so it is not
yes,
about treating them in needles and plasters and everything. You need to look at the age of the patient, the duration of the symptoms, and the tightness of the compartment. I.e., if they have Tinel, reverse, a Phelan and Phelan present, that means the compartment is very tight. Okay, so if this person is 90 years old, he has this for 2 years, and he has carpal tunnel syndrome, will you operate on this patient?
sir, if there is no muscle weakness, I would counsel them. So there will be no recovery of the muscle, but the
Okay,
symptoms can mildly improve.
okay. So you must understand is you do operations for for three things. You reconstruct things, you cure things, and you stop things. You understand?
Yes,
So
sir.
if you're an old person, if you have an old person, 90-year-old, and he has got duration of 2 years or more and he's getting muscle wasting, you still will operate on them, because if you don't, they will lose complete function of that nerve. So we're not
Yes, sir.
able to revert it, but you can stop the progression of the pathology.
Stop progression. Yes, sir.
Exactly. So understand the concept, just don't go what your books tell you. You must understand what you're doing. So carpal tunnel is a very complex thing. Unfortunately, we take it very lightly, but there is a lot of things to it. You must consult the patient that you are 90-year-old, your progression has been for so long. I will still want to operate on you, because when I do operate on you, it will make you stop from having further problems. However, at the moment, I cannot guarantee that you can get normal again. Okay.
Yes, sir.
So do you see all these lines here? What are these lines for? Do you know these lines? Line
Yes, sir.
number 1, line number 2, and line number 3.
Sir, I'm not familiar with line number 1, but 2 and 3, I'm familiar with line number 2, sir.
So when you
Sir,
draw a line parallel to the thenar crease, yeah? Can you see this line going parallel to the thenar crease?
yes, sir.
And if you
Okay,
draw a
yeah.
line parallel to the thenar crease, anything distal to that is where the motor branch of it comes to it. So your incision should not go beyond that.
Okay, sir.
So the motor branch comes there. So if your incision stays here, you are guaranteed to not touch the motor branch. If you go beyond that, there is a high risk you may touch it. This is the line where you do your incisions on the ulnar border of your ring finger, yeah, the number 2. And number 3 is the radial border of middle finger, and that plus this line will tell you where the motor branch is. So 1 and 3 come cross together to tell you where the motor branch of the median nerve is.
So line 1 and 3.
Yeah, 1 is the thenar eminence.
Thenar eminence.
And then 3 is the radial side of the middle finger. Where that line crosses, there is a high chance that's where the motor branch is going to be.
So, line 3 is danger zone.
Yeah. Safe side and suicide, yeah?
Yes, sir.
Okay. So much to do, you guys, I don't know where you guys are at the moment, back in the day. What's a mallet finger?
Sir, mallet finger, sir, it is the rupture of the extensor tendons in the DIP.
Yeah.
It is usually the lateral cord, sir, or it is the fracture avulsion.
Okay, so what you have to say is insufficiency of the extensor tendon to the DI3 joint, yeah?
Yes, sir. Insufficiency.
So then
Yes,
you look
sir.
at an X-ray, and you look at an X-ray, and then you find out whether there's a bony attachment or not. So
Or not attachment.
if there is no bony attachment, you can manage this in a mallet splint, okay?
Hyperextension.
Yes, sir.
So if there is a bony fragment, then you have to make sure that it is not more than 15% of the whole articular surface. It is more than 15%, then it becomes unstable, and you have to somehow either fix the fragment or allow the finger to hyperextend in such a way that the fragment is allowed to heal. Okay, that's all you need to know about mallet finger, yeah?
Yes, sir.
Okay. One more, and then I have to.
Along with that, sir, mallet fingers, chronic mallet fingers leads to swan neck deformity, sir.
Absolutely correct. Why?
So,
because of
Because of?
the volar subluxation of the.
Yeah, so remember, tendons are not cut, and the unopposed tendon will put it in the direction. So when you have a mallet deformity, it is hyperflexing, okay? So whatever tendon is available, it will have to pull it back again. So therefore, the other tendons goes to the side because they fall exactly like rheumatoid, and then you get what is called a swan neck deformity in the long term. Yeah.
right, sir.
Sir, I also want to ask one question from the carpal tunnel, which we usually get in our theory paper. Is that they ask what is the most common cause of carpal tunnel syndrome, and in the options they give us synovitis, along with hypothyroid, diabetes mellitus, and rheumatoid.
Yeah. So in rheumatoid, you have hyper vascularity of the synovial tissue, so they proliferate. So this is one of the reasons of carpal tunnel. In diabetes, they've got a new neovascular genesis inside. So then they have hypertrophy of the synovium. So whatever causes increase or decrease in space will give you carpal tunnel. But the commonest cause of carpal tunnel is putting on weight, swelling and putting on weight. So what were the options you had? Diabetes, rheumatoid, and what else?
Diabetes, synovitis, and rheumatoid.
So synovitis would not give you a decreased space. So I think of those three, diabetes is the most commonest then.
Right, sir.
Huh?
Diabetes.
Diabetes. Hyperthyroidism also.
Okay.
Terry Thomas.
Terry Thomas sign, yeah. Go on then. Let's talk about Terry Thomas sign then.
Sir.
Who was Terry Thomas anyway?
He was an actor. That's all we know.
Is what, sorry?
He was an actor. That's all we know, sir.
Yeah, he was a comedian. He was a British actor, and he had a big space between his two teeth. So his picture looks like the Terry Thomas sign. Okay, so that's
Yes,
why
sir.
But in America, they call it something else.
It's called?
We don't know.
What is it called in America? It's not called Terry Thomas.
Sir, don't know, sir.
Yeah, it is called Madonna sign because Madonna's teeth have got.
Madonna.
There are a gap between the teeth of Madonna, so it's called Madonna sign. Okay, so but what is this anyway? Have a look at this X-ray. I don't have a lateral of this picture, which is a shame.
Sir, it is the destruction of the scapholinear ligament.
Yeah, but there's something else happening here, isn't it?
Yeah, sir.
It's a fracture of the waist of scaphoid.
Yeah.
Yeah. So you know carpal instability, you know, and there is a DZ and a VZ. Do you understand? We'll do this last and then we'll call it a day, yeah? Because I have to go to
Yes, sir.
So what's a VZ and what's a DZ? And do you understand what that actually means?
Sir,
Dissociation of the scaphoid unit and the lunar triquetral intact ligament takes it into dorsal angulation.
Okay.
That's why in the lateral view we get the cup of the lunate tilted dorsally.
So understand that
And vice versa.
the whole world will go the good way, not the bad way. Can you understand that? So there is an intercalated segment.
Yes, sir.
Intercalated segment is between scapholunate and lunar triquetral. There are ligaments holding the triquetrum to the lunate and the lunate to the scaphoid. Okay, so this is called the proximal intercalated segment, which is attached to each other with ligaments. Now, if you have a scaphoid fracture, scaphoid fracture, or you have a scapholunate deficiency, then the lunar triquetral ligament will be intact. Okay, so the lunar triquetral ligament will extend the lunate. Okay, and then you get a DZ deformity. If the scapholunate is intact, it will flex it, and therefore you will have a VZ deformity. The whole world goes with the good person. So if the ligament is intact, it will go in the direction of that. That's the easiest way to understand VZ and DZ. Okay, the ligament.
The lunar triquetral extends.
Is what, sorry?
The lunar triquetral extends the.
Yes, so it will give you a DZ deformity when you have a scapholunate insufficiency or you have a scaphoid fracture, because there is nothing to pull it in the direction of the scaphoid.
Right, sir.
You must understand concept, not rectify or memorize it, isn't it? So,
Sir, we try, sir.
you're all in the beginning of your careers, you know. I mean, I have done 17 years of this. So, but the thing is that I always wanted to read, and I always study, and I always want to know more. And the exam is not when you finish your exam. The exam will start when a patient sits in front of you and says, "Dr. Saab, mere haath mein dard hai." You know, you can't run away.
Yes, sir.
So, but try to pass your exams, because you can't get on the step unless you pass your exam. Once you pass your exams, then you're on the ladder and you can succeed afterwards in various ways. But I mean, I will do this every Sunday. It's just that I was on call. I've got teaching to do on Sunday, and I've got various other things. So hopefully we will continue every Sunday a topic that you guys want to do and talk. And the more
Inshallah, sir.
the better you guys are going to get. All about
Yes, sir.
It's all about practice, repeatedly answering questions. So I've told you more about carpal tunnel today in 20 minutes than you've ever learned in your lives and books, isn't it?
Yes, sir.
And you will remember this. You will remember this in the exams. Okay?
Inshallah, sir.
Inshallah. Okay. I will go now because I've
Sir.
got work to do. But hopefully, if you guys want, let me know. We can do something on Monday also, because I'm free on Monday. The bank
So
holiday.
this Monday or coming Monday, sir?
I mean, in 3 days' time. I'm free.
Okay, sir. Inshallah.
If enough people want it, I'll come and do some topics with you guys. But
Sure, sir.
10 o'clock in the morning
Sure, sir.
for me, which is 2 o'clock for you. Today was a bit late because I've just come and done my ward round from on call.
Okay.
Yes, sir.
Let me know then.
We'll
Okay.
be ready, sir.
Let me know.
Sure, sir.
So we'll call it a day, and we'll come back hopefully on Monday then. Yeah.
Yes, sir.
Right,
Thank
sir.
you, sir.
No worries.